So you have to can you hear me? Fasten your seatbelts. So this is a pretty quick trip through the history of Rett syndrome. There are many in the room that I can see who have been here before and may have heard this, and I hope I changed some of the words. We wouldn't be here if it weren't for this gentleman. Unfortunately, he passed away in the end of the 19th, the last century, 20th century, end of the 1900s. And he left us before the gene was identified. But still, he made the recognition of this diagnosis probably already in the 1950s, but he didn't write about it until 1966, and he wrote in German in the Vienna Medical Weekly newsletter. So it was not well read across the world. At the same time, this gentleman, and I should say Andy Rett is a developmental pediatrician who was responsible for all child development issues in Austria at the time. This gentleman, Bengt Hagberg, is a pediatric neurologist. He's now over 90 years of age. I saw him about 2 years ago. He is in good physical health, but his mind has slipped, so it's sad. But he was making the same diagnoses in Sweden at the time. Unlike Andy Rett, he didn't travel around Europe and try to proselytize, I guess, or recruit other physicians to say, have you ever seen this? And I would say probably half of the physicians said, well, maybe I've seen it, but I can't remember exactly. And the other half said, I don't know what you're talking about. I think you're just making this up. This is just something about developmental disability that everybody has been seeing, and it doesn't have any special significance. This carried forward in the next decade, and finally Hagberg recognized that one of the distinctions between the two sets of families that they were seeing was an elevated ammonia level in the patients in Austria. Turned out that that test was either done incorrectly because the machine wasn't calibrated properly or the blood wasn't handled correctly. And when Bengt Hagberg found out about that, and he said, well, we must be looking at exactly the same set of girls. And therefore, he got together with Jean Cardi, who is a great and world-famous child neurologist in France, and 2 child neurologists from Portugal, and they presented this paper in the Annals of Neurology in 1983. And at that time, nothing really was written in English, and so that became a worldwide explosion of knowledge and interest in this disorder at that time. And it was as a result of this that I had the opportunity to see my first set of patients. Let me hope this plays. Now there is sound with this, and I can hear it, but so she's holding her breath, and then she breathes fast after she exhales air. She has these hand stereotypies. You'll see her walk in a minute, and it's unusual. So she walks backwards somewhat, sometimes, walks on her toes, and doesn't walk really in a purposeful fashion. This girl, on the other hand, and this is a reason I show this, is she doesn't walk, and look at her ankle or foot positions. She's 6 years old at the time.
And she's very afraid of falling. She can't touch the floor.
So she's very anxious.
Now she might not fall, but she would straighten right up.
She can straighten it out, right? Oh, yeah. Okay, this is not a contraction. This is clearly a dystonia. Okay.
So
She does it for
that individual is Joe Jankovic, and he is an adult neurologist and expert in movement disorders. And what he said was, this is not a contracture, this is not spasticity, this is a dystonia. It's a problem that's very, very common in girls with Rett syndrome, both at the ankles, sometimes at the wrists. And the critical feature of this is to, if it occurs, is to pay attention to it, always to make certain that the joint, whichever it is in a neutral position. And if you have to do that with supporting devices, braces, AFO, ankle-foot orthoses, then it's really essential, because if you don't, it will become a contracture. So it has to be maintained in a neutral position. I'm going to talk about the clinical diagnosis and how we currently make the diagnosis, and it really hasn't changed over the past 30 years. So Rett syndrome, we understand now, is a disorder which generally occurs in young females. It's associated with cognitive impairment. However, we are not in a very good position to assess that accurately because girls don't communicate or talk in a proper way, and they don't use their hands, and that's what psychometric tests are based on. So it's really difficult to make a judgment as to exactly what the cognitive level is. And we heard yesterday at the scientific meeting that we are probably greatly underestimating the cognitive abilities of these girls. They have a communication dysfunction, obviously. It's not only that they don't talk, but sometimes they don't give very good eye contact, and there is a period of time in their life, often from about a year to maybe 30 months of age, where they may not interact much at all. They develop the stereotypic hand movements, and in general, there is a failure in growth. However, there is a clear temporal profile that allows us, when we see this, to pretty clearly make the diagnosis. These girls are apparently normal in the first several months of, or if not more than that, a year or a year and a half of life. Now I say apparently because if you look at the early skills that they acquire, yes, they do acquire skills, but they don't acquire them normally in time. So when we looked at that in our natural history study, about 30% of the time, or perhaps up to 50%, the skills are attained on time, the early skills, sitting, walking, perhaps beginning communication, or saying a few words, but then they are lost. So there's an arrest of developmental progress, followed by a frank regression. When they lose, and by the word lose, we don't mean they lose it completely, they lose it partially or totally. The ability to communicate and the ability to perform fine motor activities with their hands. Finger skills is what Bengt Hagberg would call them. Later on, perhaps by 30 months of age, or certainly by age 5, there's a stabilization process that is recognized. The girls give very, very good eye contact, although it may be intermittent. So they look at the target, look at you, look away, look back. And I can say from seeing many girls that they recognize me after I've seen them more than once, and they look at me, stare at me. And it's a clear recognition. So their eye contact, their interaction really don't change at all. If anything, they get better throughout life. However, there's a gradual process of motor slowing. So initially, these girls are low in muscle tone. And many times the pediatrician or the child neurologist will describe them, frankly, as floppy. At some point in time, it's variable. The girls transition into normal tone and everybody thinks that things are good. And they are good, but then the tone begins to increase until they develop an increase in tone, or more like a rigidity that you see in Parkinson's disease or disorders of that nature. And that may occur as early as 10 or 15 years of age or as late as 20s or 30s. In 1999, Ruthie Amir, working in Huda Zogby's laboratory at Baylor College of Medicine, through a series of discussions with Ine Vandenwever, the second author in this paper, provided samples that we had obtained there of blood for use in a controls an experiment of another nature. And it was determined that these cells weren't working properly. And therefore, Ine convinced Ruthie that she needed to look at the methylation patterns of certain genes on the X chromosome and identified mutations in a number of girls who had Rett syndrome. And that was really the beginning of a launch of basic science research, which has really brought us far along, as I mentioned last night. We're already at the stage of clinical trials. And I think that's a fairly rapid process for science. Now, it may not seem rapid for you, and I understand that because you want to have something done now, and we understand that. But the process of understanding and learning how genes work and how we can interact to reverse the abnormalities that they may produce takes time. And we are as impatient as you are, believe me. So even though mutations have been identified, not every girl with Rett syndrome has a mutation, although in our hands more than 95% do have a mutation. But even some girls who have mutations don't have Rett syndrome. They have other features, other disorders, and in some cases, these are mothers of children who have mutations in MECP2, who for reasons of, principally we think of X inactivation, where their normal X chromosome is being expressed in all of their cells, or most of their cells, as opposed to our more random 50-50 process, they appear clinically normal. We make the diagnosis based on a set of criteria that have been modified over time from the past 25 or 30 years, and they've been streamlined, and the words have been nuanced so that they are interpretable by all languages, because we recognize that over the course of the previous iterations of these criteria, we were confusing what we meant with what the other people with other languages were understanding. So the first and most important feature is all girls with Rett syndrome have to go through a period of regression. And then there are four principal characteristics that associate this disorder. One is the partial or complete loss of purposeful hand skills, the partial or complete loss of communication or spoken language, gait abnormalities. Most girls learn to walk. Not all girls maintain walking, so by the time of, let's say, adolescence, about half of the girls are able to walk, and another 20% or so are able to walk with assistance, some being fairly modest assistance, others being fairly significant assistance. And about 20% of these girls never learn to walk, and another 10 or more percent lose the ability to ambulate for a variety of reasons. And then the stereotypic hand movements, which really sets this disorder apart. These movements go on throughout the waking hours. They disappear in sleep. They may disappear as well, and Andy Rett noted this, in situations of mild infections, where the girls just don't feel right, and the hand movements go away. And then when they come back to getting over the infection. Hand movements are back. We have a number of exclusion criteria to make certain that we aren't missing or confusing other situations which may produce some of the same features. One of the things that you should notice is what is left off here is the issue of microcephaly or decline in head growth. And although most girls undergo that, it's not 100%. So we did remove that. And then we recognize that there are a set of girls, about 15% of the natural history study, who meet some but not all criteria for typical Rett syndrome, and we call them variant or atypical Rett syndrome. They have to meet 2 of those 4 main criteria that I described, and then 5 of these 11 supportive criteria. And I'm not going to read through them and bore you with them, but they are features that we see in many of these features in girls with Rett syndrome and also with atypical Rett syndrome. So what we have learned about Rett syndrome, both through the natural history study and through other studies around the world, that more than 95% of girls with Rett syndrome will have a mutation in this gene. There are 8 common point mutations. That's a single nucleotide change in the DNA molecule, and they account for just about 60% of all mutations. And then there are another class of mutations called deletions or insertions. So nucleotides are removed or extra nucleotides are inserted, which messes up the interpretation or the coding sequence of the gene. And they account for perhaps 20%, or maybe slightly less. That means that of the additional 200 and so mutations, they occur fairly uncommonly and may actually in some cases occur only in a single individual. So there are many, many mutations, but a relatively small number account for most girls with Rett syndrome, and that's because these mutations represent certain critical key regions in that gene. We know that Rett syndrome is sporadic. It occurs, it is not in general present, the mutation, in either parent. It's something that occurs spontaneously in the germinal cell line, and the germinal cell line that's turning over constantly is the sperm, because the eggs really don't change very much in the female. So not all, but a bulk of the girls are a result of new mutations occurring in the sperm. Now I hasten to say that this is not meant in any way to assign blame or guilt. You shouldn't be guilty. You have no control over these spontaneous mutations. They occur, we call them de novo. They happen out of the blue. Rett syndrome in a familial sense is very, very rare and unusual. It does occur, but it's unusual, and probably well under 1% of all girls with Rett syndrome have related or other members in the family who have the gene mutation. Those families have been very important and were critically important in identifying actually the mutation, because you can do analyses and limit the parts of the X chromosome that could be related. The variant forms of Rett syndrome, as I said, account for about 15%, and of those, roughly 3/4 will have a mutation in the gene. And we have learned many other things, and we could talk here for probably hours. So Rett syndrome occurs in females mainly, but the variant forms occur on 2 ends of the spectrum. In one sense, the girls may be better at functioning, so they have some preservation of speech, or they have a delay in onset. So rather than onset at a year of age, they have an onset at 6 or 10 years of age. On the other side of the coin, there are children with congenital or early onset related to seizures. Ordinarily, seizures don't begin in Rett syndrome until age 2, but these early onset forms really retard any appearance of normal development. And then there are variants which have no features of Rett syndrome but look like autistic children. They may look like girls or boys, or girls, but with Angelman syndrome, which is another genetic disorder unrelated to Rett syndrome directly. And then in the last two groups, these are carrier females. They either have mild learning disability or completely normal. And the reason, as I mentioned, is because of the skewing of X inactivation such that they express mainly or only the normal X chromosome. And I think Dr. Skinner will explain more about X chromosome activation in the next, a little bit later this morning. Now on the male side, Rett syndrome has occurred in a few boys, and it occurs really in two situations. One is an association with another genetic disorder, Klinefelter disease, in which there are 47 chromosomes and 2 X's. So from a chromosome perspective, they do have the appearance of females, and one or the other of the X chromosomes is inactivated, and therefore they can express features pretty typical for Rett syndrome. And a second group, also with two populations of cells, are children with what we call somatic mosaicism. So after conception, some point in time, two populations of cells develop. Beyond that, Rett syndrome is pretty unusual, and we probably can count on two hands the numbers of either one of those that have been described in the literature. There are also mutations that occur in girls with Rett syndrome, but in boys, in which they occur, they lead to either a much more significant disorder with survival rarely beyond a year of age because they don't breathe well, or there are boys with mutations farther out in the gene who have cognitive impairment and may or may not have progressive motor problems, either with spasticity, as listed here, or dystonia. And finally, and although not related specifically to Rett syndrome, the MECP2 duplication disorder is a separate disorder. And now instead of having no or limited amount of normal gene, these boys have 2 copies of the gene in every cell. And it's been learned in animal studies, but also in humans, that this gene is tightly regulated. And if you have more than 1 copy of the gene per cell, it's probably as deleterious as having no copy functioning. So there are a number of medical issues, and I'll go through these fairly quickly, and we can discuss these later on if you wish. So growth is a problem. They generally are short in stature. They are small and low in weight, generally. But the first clinical finding that one may observe is the deceleration in the rate of head growth, which can occur already by 1 or 2 months of age. The hands and feet are also tend to be small, the feet more so. I can't see this slide very well from the angle, but you can see these are 2 growth curves for the normal population, which is the top part and is in gray, and the Rett population, which is in pink. And the heavier bold line is the 50th percentile, and you can see that the 50th percentile for the Rett population falls below the 50th percentile already in the first few months of life. And it crosses the 2nd percentile very, very early. These growth charts are available through rettsyndrome.org, and you can access them there and send them to your pediatrician. Have them use these. You can see there are similar changes in weight. Perhaps it's a little bit later that they begin to deviate from the 50th percentile. And the 50th percentile line in the Rett population crosses the 2nd percentile in the normal population a little beyond age 12. And similar information for length. So that in general, girls with Rett syndrome are rarely meet 5 feet in height. They can, but they rarely do. And they are usually in the order of 60 to 80 or 85 pounds. Now, one of the concerns that we have had, that we've noticed, particularly with the attention we've been given by our dietitian, is once the girls go through puberty, they may gain weight. And that's not good for them, and it's not good for you, because you have to lift them and help them in many ways. And after you do that for a number of times per day, you'll understand exactly what I mean. It's not good for your knees and not good for your back. So you have to be careful that you don't let them get too big, because once you put it on, we all know it's hard to get off. So seizures are a problem. They occur at a variable frequency depending on the study, 20 to 80%. In the natural history study, they occur in about half the girls. However, if you look across time, by the time the girls are 16, 85% will have had seizures requiring medication at some time or another. But just taking a snapshot in time, about a third of the girls require medication. In general, the seizures modify over time and they become less evident after 20. However, that's not always true. One thing that you have to be very certain, and we've seen this many times, is that girls may have events which look just like seizures, and they are not. They are called Rett events or the brainstem event. They're not normal, but they are not something that really responds to typical anti-epileptic medications. And in order to make that diagnosis, you have to do a video EEG assessment. That means the girl has to have an event while she's being monitored, and one can tell whether or not it's really a seizure by that. Some girls require either vagal nerve stimulation or a ketogenic diet for maintenance. They can be effective, but they are not universally effective. Sleep is often disrupted. It's both going to sleep and staying asleep. It's more typically probably difficulty in staying asleep, so they wake up in the middle of the night. Sometimes they're uncomfortable, and one has to pay attention to perhaps they vomiting or having reflux and nearly vomiting, or perhaps they're just up and awake and playing. And they may laugh out, and you go in and find that they're quiet and looking around, and they wonder why you're there. But it does disrupt everybody's sleep to have them awake, and so we recommend strongly that when they become a problem, they need to be medicated. Antihistamines can be good in the short term, but one develops tolerance to these medications pretty quickly. Melatonin can be good in helping children go to sleep. It's not really good to maintain sleep, although there are long-acting preparations that are now available which may be better than the initial short-acting medications. Beyond that, we favor the use of trazodone, which is a drug used ordinarily for depression, but it does have makes you sleepy. So that's a reasonable drug. It's very safe. One doesn't develop tolerance to it. And I personally, because I'm an old man, like chloral hydrate. Now, chloral hydrate is frowned upon by young people, and I'm young physicians, and I don't understand what their problem is. Or the problem with the medication is. I know what the problem is. It's difficult to take by mouth. It comes as a liquid. It's not easy to get in solution, so they put it in alcohol. So it's very, very strong. It's 5% alcohol or so. It burns the mouth. If a girl has a G-tube, you can give it at will, and it's no problem. And in many times, you can go to a local pharmacy, not CVS or Walgreens, but a local pharmacy, and they will compound it in a form that is more palatable. They can either put it in a capsule, or they can mask the flavor. And I'm told by an associate that chocolate is really the best flavor. I don't know. Breathing irregularities dominate much of the wakefulness in many girls, not most, but many girls. And it can be hyperventilation, it can be breath holding, it can be both. Many girls swallow air. Some of them swallow it pretty prominently, so they look about 6 months pregnant. It all goes away but it can be trapped in the small intestine, and there it can cause significant discomfort. So it's something to consider. This is usually most prominent during the school years, and it usually dissipates after one reaches, again, 20 years of age. Gastrointestinal issues are a major problem. They can go on for from the top to the bottom. These girls do not chew properly. They don't manipulate food in the mouth properly. They don't swallow properly because there's not a normal contraction pattern in the esophagus. There's a high prevalence of gastroesophageal reflux. And you know that if you have heartburn, that's what GE reflux is, it hurts. And it can hurt a lot. And these girls can't really tell you what the source of their discomfort is. So that's one of the first things that we focus on. Also, stomach emptying or gastric emptying may be slowed. There are medications useful for that. One of the medications that gastroenterologists have been using for years, and we absolutely detest it, is called Reglan. It's a drug that produces severe movement disorder in some children, and personally I think it should not be on a formulary. It has such bad side effects. But there are other medications. They're older medications, and they're quite effective, and believe it or not, one of them is an antibiotic, or erythromycin. And there's another one, it's a cholinergic medication called bethanechol. Constipation is probably occurs in 85 to 95% of girls with Rett syndrome, and various remedies can be used, and if necessary, Miralax is a very good drug or agent. It's a powder, mixes up in a liquid, it's tasteless. It is, however, something about it these girls can recognize when they're taking Miralax, and they may avoid it, but you have to mask it as best you can. Give it on a regular basis. You may vary it from day to day based on either their diet, but also how much liquid they take. They must take liquid to make it effective. Miralax is not absorbed in the GI tract. It actually pulls water in, and if they are dehydrated, they're not going to have enough water to pull in. So they have to be well hydrated to make that work. In other cases, girls may have either alone or in addition benefit from the use of milk of magnesia. Now, I know when I took milk of magnesia, it was not palatable. There are now more palatable forms that one can take. Again, if girls have a G-tube, it's pretty easy to give them. Nutrition is a problem. They have to have adequate calories. If they aren't getting adequate calories, a G-tube is really essential. In our study, about a third of the girls, or probably a little less, have a G-tube. That doesn't mean they can't eat by mouth. They can eat for pleasure. They can eat a substantial amount. But when they don't eat, you always have the route of feeding them through the stomach. It is a device ordinarily that's flush with the stomach. It doesn't keep them from doing anything. It's not evident. They can go swimming. So it is, I understand the reluctance for any surgery, but it is actually in the surgeries, it's relatively minor, and it is something that many, many families come to, and if they do come to it, they say, we wish we'd done this earlier. We look at the body mass index as a measure of how well girls are nourished, and we'd like to see the girls at least above the 10th percentile in the normal population. Osteopenia is a problem in girls with Rett syndrome, particularly girls who don't ambulate. And osteopenia is kind of on the stage to osteoporosis, so it's not quite as bad, but it does mean that the bones are not as strong as they could be or should be. And so the fractures are much more frequent in girls with Rett syndrome, spontaneous fractures or minor fractures based on trauma that you may not even see, as opposed to other typically developing children. The fact or failure of a girl to use a limb is a big red flag. something that ought to be kept in mind. Regardless of age, vitamin D is now recommended, and we've pushed this up to 800 international units per day. Oral calcium is also important, and that has a change with age. So you need to speak with your pediatrician, general physician, or they need to get advice from a nutritionist as to what the correct amount of calcium is per day. Many of the girls do not like milk, and so you have to make up for it some way. And an easy way to make up for it is the Tums smoothies. They have a high level of calcium. They're dissolvable and crushable, so they're easy to give, and they're either fruit flavored or mint flavored, so they're palatable. Scoliosis is a problem in many girls, particularly in girls who are not ambulatory. But we know that if you can keep the girls in a good posture when they're sitting, you can really obviate many of the significant problems. When the curvature exceeds 40 degrees, it's time to at least consider surgery. And in our study, about 13% or so of the girls have had scoliosis, and almost without exception, the families are impressed that the quality of life of these girls is much, much better. As I already talked about walking, but this is an important thing. It's important to maintain walking, to push them as much as possible. Even for girls who can't walk, standing in a standing frame is very good to promote, first, a good look at the environment. It's better than lying down, but also to promote bone health and muscle health, because they do have to put their weight on their lower extremities, and they have to bear some of the responsibility in standing. Sexual maturation is one of the features of Rett syndrome that probably occurs normally. I say that advisedly. A certain percentage of girls with Rett syndrome actually have early onset of puberty, that's before 8 years of age, and on average their periods begin about a half year later than in the general population. But still they do occur, and one has to deal with that in any way or best way you want. In some cases, the periods are pretty modest, and you can deal with them as though you would deal with anything. And changing a diaper is probably worse than changing a pad. So you can just deal with it. In other cases, the flow is pretty heavy, and you may want to modify that by using birth control medications. One is low in estrogen. And the reason for that is particularly in girls, again, who are non-ambulatory. There's a certain risk for blood clots. It's very low. It's related to the estrogen content. We've never seen a problem, although I know they have occurred. But there are many, many routes to go. I think that the management strategies require that you talk to either an adolescent physician or a gynecologist and go through all of the possibilities. Now, the cardiac conduction system is also a concern. We know that these girls have a higher frequency of prolonged QT syndrome than the general population, such that we recommend an EKG at the time of diagnosis and an annual visit every annual visit with the physician. The QT is a simple calculation. It is done automatically by the machine, but it should be validated by a cardiologist, one who actually puts calipers on it, does the correct measurement, because the machine is a conservative instrument, and it makes perhaps diagnoses in more cases than it's really there. The autonomic nervous system is peripheral autonomic nervous system is something that we have some concerns about. The hands and feet are typically cool, the feet more than the hands. Sometimes they're cool all the way up the lower extremity, certainly to the knee. The girls do not appear to be uncomfortable with this, although I think I would be to have a extremity that is as cold as theirs appear to be when I examine them. We think this is related to an excess in sympathetic tone, and there is little in the way of medication that one can deal with it specifically. Bruxism and teeth grinding is ordinarily an early sign. It can be pretty annoying. In other cases, the families say, well, we don't really hear it anymore, even though it's going on, and we can hear it in the clinic. It is a time-related phenomenon, ordinarily disappearing by the time they're 10 years of age, or it becomes less prominent. But it has a very distinct sound that Bengt Hagberg described as slowly uncorking a bottle of wine. If you can remember that sound or recognize it, it can be pretty annoying. I've already talked about the muscle tone, but again, there's a transition of tone from hypotonia to normal tone to increased tone or rigidity, much like that seen in Parkinsonism. And attention needs to be given to that. But in addition, these girls often have tremor, either at rest, and particularly when I do something that takes them off their center of balance. So if they're sitting in a chair or on a parent's lap and I take them and put them on their feet, they become very tremulous. That means to me that they are uncertain or have a fear of falling. But they do calm down. And some of the reasons that girls stop walking is because they have that same fear that they're going to fall because of their inability to maintain posture. We often see myoclonus and choreiform movements, oral motor dyskinesias, which can be very prominent and disrupt their lives momentarily at least. And finally, the longevity in Rett syndrome is something that's of great interest. In a study that we did both before the natural history study and we verified it in the natural history study, survival of girls with Rett syndrome is normal through age 10. Then there's a greater loss of girls with Rett syndrome than the general population, and survival is ultimately about 52 or so years for half of the population. So that's well short of the normal female survival, which is close to 80% or more. But still, it's much longer than the original population seen by Andy Rett. I think that is a tribute to you, not to anybody else, but to you because of the greater emphasis on therapies, making certain that they're properly motivated, properly manipulated, and have proper therapies in school. So research today, our natural history study was to enroll 1,000 girls. We've actually enrolled more than 1,100. We have 920 some with, and I'll show you, with typical Rett syndrome, and 160 some with atypical Rett syndrome, and a small number of other girls and boys, either with features of duplication disorder or with features related to mutations, but not Rett syndrome. The purpose was to understand the natural history of the disorder and to make genotype-phenotype correlations, that is, what the girls look like compared to their mutation. We have sites at these 4 centers, and we recognize that that's pretty much cuts out the most of the country because we're on the East Coast or the southern part of the country. So we did travel clinics, and we did those from 2006 to our last clinic was in June in Florida. We are not planning to continue those, not because we don't want to do it, but because we have developed expertise in all these centers around the country, and we can now use physicians there to be part of our network. So the current enrollment, as I said, is nearly 1,200. We have 40% or so that were enrolled through the travel clinics. You can see the numbers for typical and atypical Rett syndrome, and those who are MECP2 positive or have a duplication but don't have Rett syndrome. And this is one slide on the mutations. And I'm sure you can't see that because I can't see it. But the curve to the left side are girls that have better performance, and those are certain specific mutations, and these are the common ones. And then the girls group on the right are specific mutations which they have a slightly worse, or maybe significantly worse function. But interestingly, at the two tails, they're pretty close together. So what that indicates is that even though you may have a girl with a so-called milder mutation or a severe mutation, you can have two girls with that mutation and they may look dramatically different. So there are other factors than the mutation, additional factors that relate to the severity of this disorder. They're complicated. We can talk about it later, or you can talk about it with Dr. Skinner. About 7 years ago, it was reported that if you had a normal gene in an animal under the control of a controller, but it's not going to be expressed until you give the drug that activates the controller, and you activate the gene at some point in time, both in male and female animals, you can reverse pretty much most of the features that one sees in the abnormal animals with MECP2. So this was a proof of principle that if we had a specific therapy and we could implement it at a proper time, it would work. Now, there's a big difference between a mouse and a human. And we know the translation of information from clinical trials in animals to humans has not been all that positive. So the treatment may work in an animal, but in less than half the time, it does not work in the human. And there are probably different reasons for that. But at least this was a proof of principle. So research had been directed really at trying to find disease-altering medications that can be useful. And they've relied on a number of different strategies in animals, so whole animals, slices from the brain, single cells in culture, cultured cells from girls with Rett syndrome. We convert them back to stem cells, promote them with certain growth promoters to create neurons or glia, cells that produce white matter. And you can study those and use those as test vehicles or test beds for a variety of therapies. So there are a number of pharmacologic approaches that have been used and are being considered. And these are trials that occurred in the past, and of only one, the lamotrigine study, was effective. And this is a very good drug for seizures. However, if I'm a child neurologist, for me, it's a very painful drug to give because it takes about 2 months to get up to a treatment level. So it's very slow. And we're not patient people. We need to get it to treatment as fast as possible. But it is a very good and safe drug ordinarily. Gene therapies. There are animal studies showing an effect of gene delivery in the brain, and there are still problems that have to be worked out with it. But we have to remember that from the duplication studies, if we overexpress this gene in a cell, we can make things actually worse. So that's one concern. Stem cell transplant has been tried. It was successful in the first trial, but there have been 4 subsequent studies in separate laboratories which have shown it to be ineffective. There was some important information that came out of that from the microglia, and perhaps a pharmacologic study might be helpful in that regard, so a drug, but the actual use of stem cells is probably would have to go back to the drawing board. And another is the alteration of the X chromosome inactivation pattern. That's a long conversation, but if you could activate the normal gene, normal chromosome, in the cells that are not expressing the normal chromosome and leave those that are normal alone, and that's a big if, you would have a correction. That is something that's theoretically possible. It's being discussed not only in Rett syndrome but other X-linked disorders and other disorders as well. So I would stay tuned, but it may be many, many years before we solve that riddle. There are many symptomatic therapies or perhaps disease-altering therapies that are either in progress or being discussed. There are so-called serotonin reuptake inhibitors, which are important for ameliorating anxiety. The NMDA receptor drugs have been in trial already in Fragile X syndrome, and they're being considered in Rett syndrome. The IGF-1 drugs, both the full-length molecule and the short tripeptide, are in clinical trial, and I mentioned that last night. And we should have answers within the next 6 months in the case of the tripeptide, and within the next year in the case of the full length. And BDNF-like compounds are also very important. BDNF is brain-derived neurotrophic factor. It's not it's an important element in developing synaptic connections in neuronal maturation maintenance. However, it's not a product that can be given by mouth because it doesn't cross the blood-brain barrier. But there are compounds that have BDNF-like effects that are being evaluated. And there is another set of studies, and that can be restoration of the existing MECP2 problem. So if you have a missense mutation, that means you have a mutation in which an amino acid is changed so the protein isn't completely effective. If there is some way to modulate that and make the protein effective, so that's one idea. Or in the so-called nonsense mutations where there's a premature stop in the synthesis of the protein. If you can, and a number of drugs can be used for this, if you can have the cell make the full-length protein and then couple that with the same strategy used for the missense mutation, perhaps we could think of that as a means. And finally, the deletion and insertions, that's more complicated and difficult. So we have a large team that's been involved in this for many years. Actually, it began in 2003. And I can only tell you that this team has worked very hard, and it's a very close-knit group. We've worked with funding from the National Institute of Child Health and support from URSIF, or RettSyndrome.org now. And we obviously couldn't do that without the help of all of you and your daughters. And I'd just like to show you a picture of a young girl that we see in California. You can see this eye contact, that's real. And this is my first friend, the girl you saw in the video. She's 33, I think 34 now. She's still ambulatory, and she is a joy. So thank you very much.